On behalf of our panel, thank you for hosting us at John Jay today. On a personal note, I want to thank you for paroling me from Washington, if only for a few hours. Sometimes our focus can be derailed by other matters, but I can't think of anything that requires our attention and action more than the American tragedy that is the opioid crisis. By now, we're all too familiar, with the horrific 2016 numbers, as Steve alluded to. 42,000 plus dead from opioid-related overdoses. 11.5 million people have misused prescription opiates in 2016. And by some estimates, the related economic costs top $504 billion. With your indulgence, though, I'd like to read something that particularly struck me while I was preparing for the panel today. Quote, "The consciousness of the nation has not really focused on the problem. People saw this as a state and local problem. This is truly a national problem. This kind of sneaked up on us." End quote. President Mason may find them familiar words, but they were spoken by Eric Holder in April 2014, 4 years ago, at a gathering of America's top law enforcement officials in Washington. What he said that day, sadly, is again what draws us here today and raises questions our distinguished panel will confront. Why was our country late to recognize a problem that is now an epidemic? Were we late? While the Trump administration has declared a national emergency, does the government's plan match its rhetoric? What is law enforcement's role here? And how prepared are local police to confront this problem every day on America's streets, since they are on the front line? And how should public health partner with police? And is it time, as the Washington Post wrote earlier in the week, to embrace alternative strategies, such as the managed injection sites that now exist in British Columbia, Canada, and which are being eyed as options in San Francisco and elsewhere? As I mentioned, our panel is here to answer these and other questions. They have some remarks to share with you today before we dive into a conversation on the panel and then open it up to questions. But first, let me introduce who is with me today and who will provide you the real information. José Diaz-Briseño is the Washington correspondent for Reforma of Mexico. Between 2013 and 2015, he was the Washington correspondent for Mundo Fox. His reporting covers U.S.-Mexico affairs, including immigration, drugs, trade, and border security. He's been a busy guy. Chief Paul Sell. We were worried about Chief Sell. He was earlier in the week, I was told that an illness may prevent him from coming here, and I crossed out his bio when I heard that, but it taught me one thing: you never underestimate a cop. He's going to show up no matter what. Chief Sell is the first vice president of the International Association of Chiefs of Police, and incoming president. He is a 37-year veteran of law enforcement and has served as the chief of police at the Montclair State University Police Department in New Jersey since 2001. Chief Sell is a member and past president of the New Jersey State Association of Chiefs of Police and chairman of the New Jersey Police Chiefs Foundation. Welcome. Rita Noonan. Should I call you doctor? Okay. is the leader of the Health Systems and Trauma Systems branch in the Centers for Disease Control and Prevention's Division of Unintentional Injury Prevention. It's a mouthful. Where both drug overdose and traumatic brain injury prevention activities reside. Prior to joining CDC, Rita worked as a sociology and women's studies professor at the University of Iowa. Cheri Walter. Cheri is Chief Executive Officer of the Ohio Association of County Behavioral Health Authorities. Ms. Walter has provided more than 35 years of diversified, progressive leadership and management within nonprofit organizations, large state departments in Ohio. She holds a Master's of Administration from Tiffin University and a BA in Community Health and Recreation from Bluffton College. Most importantly, Cheri notes, is the fact that she is an individual in long-term recovery and truly believes that recovery is beautiful. So we can't wait to hear from her. So let's dive in. I'm going to start with Rita first, and actually I'm going to move down here because I think it might be a little bit better.
5 to 7 minutes. Okay. Time myself on my phone, which shows that I'm a young person, right? I too am antiquated. I really enjoyed the comment. This is a similar challenge for short people. Thank you. Thanks very much. Well, it's a pleasure to be here. Good morning, everybody. And I appreciated the opening comments. I think we've really set the stage nicely for a lot of what will come up. I'm going to time myself. There's so much to talk about, and I will restrict myself to 5 minutes, which will go very quickly. But I think just by way of starting, we always talk about this as an epidemic and a crisis. And it truly is. It meets the public health definition of an epidemic, which is a sharp increase or spike in the outcome of interest. But I really prefer to talk about it as waves of an epidemic. So when we think historically, and this is how CDC has approached the problem, we look first back to the prescription drug problem, which started in 1999. If you look at prescribing, it has quadrupled since 1999, if you look over the past 15, 16 years. Pain that is reported by Americans has not quadrupled. However, deaths quadrupled, treatment admissions quadrupled. So clearly there was a prescribing problem. We have lots of evidence to suggest that. And I think that a lot of the work at CDC and partner organizations have done a reasonably good job of identifying what we can do about that. We work through state health departments. We know that prescription drug monitoring programs, for example, improved prescribing, can really try to put the horse back in the barn, so to speak. We're still working on that. We've seen some leveling off. But what happened is after priming, and this is a Dr. Frieden, the former agency director of CDC, talked about how we primed a whole population to have a taste for opioids. So what happened in the wake of that is you have heroin that arrives. In 2010, you start to see those deaths go up precipitously. And accounts from, say, Sam Quinones, some of these are anecdotal, about trafficking organizations that have really capitalized on the fact that there is a large appetite for opioids in the US. Sam Quinones did a wonderful job in his book Dreamland of talking about a particular group that capitalized on small cities in the Midwest. So if you read his book, I recommend it. It's a really great overview of kind of how we got here. So we started with prescription opioids, overprescribing. CDC has issued a guideline. We are hopeful that health systems and insurers and all of us can do a better job of reining that in. Heroin then came along, and obviously that's a very different kind of problem that requires different solutions, different partnerships. And then on the heels of heroin, now we're talking about fentanyl analogs. And I think you all know, and I think journalists have done a pretty good job of describing this problem. We know there's a problem, right? Unless you've been living under a rock, you know there's a problem. So I think our challenge now is how do we talk about this problem in ways that better reflect, I think, the evolution of this epidemic or the waves of this epidemic and the ways that we have to tackle this differently. The things that we do at the state level to rein in prescribing Makes sense to me. We fund states to do that. We have about $130 million that goes out through state-based programs at CDC. I'm happy to answer questions about that. But when the other kinds of opioids came along, heroin, fentanyl analogs, which are much more potent, I think journalists have covered that quite well. What kind of solutions do we have as a group? How do we work with, say, law enforcement? I'm a public health person. How do you work with treatment providers? How do you work with harm reduction? It's a very different array of friends and colleagues and strategies that we really have to build out. So the academics in the room, I'm very animated and enthusiastic about building out the community level evidence, and I can suggest some of the things that we're funding right now that I think are very important. But to me, the takeaway message is we need all of the creativity, all of the collaboration, all of the courage, and all the curiosity to do what has to be done now. And some of our strategies have to be different. We have to do things we haven't done before. Law enforcement, I work very closely with high-intensity drug trafficking areas across 22 states. This is very challenging. In fact, one of my friends is in here from Vermont. Where are you? There's my Vermont friend. You know, we've had very frank conversations about different missions, different worldviews, training. It's a challenge. I think we're tackling that challenge, but it's going to take a lot. It's going to take a lot of lowering our barriers and our turfiness. It's going to challenge all of us to do something we haven't done before. So I think that's really important. From the journalist perspective, in addition to being everything that I've said, curious and talking to new people, I think that we've described the problem well. I think we need more nuance in what the problem is all about now. Yes, we do still have a prescription problem. We do. It's still a significant pathway, and it still kills a significant number of people. But it's also a problem, as we've said, that has morphed in ways that we need to better reconcile. But this is a problem that is amenable to solutions. It drives me crazy when I see journalists writing about something, somebody else died, 10 more people dead, 63,000 people died of drug overdose last year. 63,000. We have now surpassed the level of HIV at its peak of that epidemic. We have surpassed the level of deaths related to motor vehicle crash at the peak of that problem. So we're talking about an enormous number of deaths. 2/3 of those are attributable to opioids. Well, what do we do about it? So in your articles, when you have a more nuanced view of the problem, talk about what can be done. I used to work in lots of injury-related fields, and there'd be a story about a house that burned down or a building that burned down, and there would be no mention in the story about smoke alarms or something that was not in that building. So talk about solutions. I think we'll talk about some of them today. I was really pleased over coffee this morning talking to somebody from the Department of Corrections in Connecticut. Justice-involved populations are very disproportionately involved. Rhode Island has new data coming out that will, I think, convince everybody in this room that we have to start talking about that. Medical provision in every institution, including corrections, should meet the standard, right? Evidence should drive medical decision-making. Medication-assisted treatment works better than abstinence. It works better than alternatives. Not for every person in every case, but if you look at a population level, that is what the evidence says. I think we need more about that. Reducing stigma. There's a lot of stigma surrounding this. Like HIV, there's some parallels in these epidemics. But we have to change the hearts and minds of people who are going to not only care for the individuals in their community, but also provide services and make decisions about policies and what is provided. So there's a long, long list of things I think we can do better collectively. As journalists, we can do better. My time's probably up. But I really look forward to hearing from everybody else. There's just so much to say. So question and answer, I can talk about CDC programs. Yes, we're the data people. We're doing it faster. We have faster death data now. We have faster syndromic surveillance from emergency departments. We work through state health departments. So we're really doing a lot, and we're trying to scramble around it and do it as quickly as possible. But again, on that frontier of working with law enforcement and lots of other partners, I think there's a lot more to do there and a lot more we need to evaluate. So I think I'll stop my remarks there and just say thank you for being here. Thank you for caring. Thank you for carrying the messages forward that people will understand. I think the president described it really perfectly. Science is one thing, but translation is really what makes it usable. We need science to action, and that's what you all are really great at. So I appreciate you, and thanks in advance.
Chief Sell.
Good morning, everyone. I'm from Jersey, so I'm not sure if I need this microphone or not, but I'm going to use it anyway. Opiates, an American tragedy. The title of this panel could not be more fitting. There is no denying it. We're facing an enormous crisis that has cascaded in almost every corner of our society. Heroin, Percocet, Vicodin, fentanyl, the list goes on. I would venture to guess that most of us in this room have seen or know someone with a substance abuse issue. In my line of work, we as law enforcement officers watch this tragedy unfold far too often. Drug trafficking and drug abuse has always posed a challenge for the law enforcement agencies and the communities they serve. We have all repeatedly borne witness to the human toll that drug abuse has taken on our society, whether it is with the illicit use of cocaine, crack, methamphetamines. However, we are now in the midst of an opioid abuse crisis that, according to the Center for Disease Control, killed roughly, depending on the number we're looking at, from 42 to 64,000 people in 2016, and that breaks down to more than 170 people a day. And as pointed out by Rita, that's more fatalities in a single year than the highest recorded number of annual deaths in firearms violence, HIV infection, or even motor vehicle crashes. So the question is, how do we get here? Heroin use has plagued the U.S. cities for decades, but recently we have witnessed a massive increase in the ability of heroin that has been traced back to the political unrest in poppy-producing areas of the world, principally Southeast Asia. This unrest has led anti-government groups to view heroin trafficking as a means of financial support. This created a glut of heroin on the drug market, which helped push it from cities into our suburbs. The heroin glut occurred at the same time as a massive increased demand for opiates. In the 2000s, excessively high rates in prescription painkillers led many to become addicted to pharmaceutical opiates. To put things in perspective, according to a shocking and, to be honest with you, terrifying report from CNBC, approximately 80% of the global opioid supply is consumed in the United States. And we consume over 95% of the world's hydrocodone. This is unacceptable. In addition to prescription opiates, has now spurred massive increase in the trafficking and consumption of illegal narcotics. In many, if not most places, street drugs like heroin are easier and cheaper to obtain than prescription drugs. So when the opiate addict cannot get a hold of Percocet or Vicodin, heroin often easily fills that void. Magnifying the heroin abuse problems is the increasing use of fentanyl, another opioid to abuse. It also is a synthetic product that is produced in laboratories. Most fentanyl these days come from China, but as we know, there's fentanyl labs around the world, and specifically in Mexico. It's either shipped to drug traffickers who put it in the heroin stream in Mexico, or to traffickers who sell fentanyl, and we see now it's being sold directly through the dark web. The attraction to fentanyl is that it's 40 times more potent than heroin, which means traffickers need to put less into the bags for their customers and more on the streets. However, the potency of fentanyl also significantly increases the risk for the user of overdosing. The potency of fentanyl poses also a significant risk for the drug user, but also for the officers and the community members who may inadvertently come in contact with the drug. Making the challenge even more difficult for law enforcement is the fact that fentanyl now is China is now producing variations of fentanyl, which we know are called analogs. These substances are molecularly similar to fentanyl, but different enough so they don't test positive for fentanyl when tested in field kits or crime labs. This impairs law enforcement's ability to successfully investigate fentanyl producers and traffickers. Most of this we all know, and that was just a brief snapshot of some of the challenges we are facing as we start to approach the opioid issue. So as we sit there and say, what now? The answer, unfortunately, is there's no easy answer. But what I do know is that law enforcement is not the only solution. The approach to this epidemic must be a three-pronged approach. There needs to be prevention, which includes education, enforcement, and treatment. Just like the three-legged stool, remove any one leg and the stool collapses. Without all three of these equally important measures, we will not be able to make positive strides. When we look at education, we need to educate our public, both in schools and the public at large, about the danger of these drugs. Part of this education campaign must be geared towards family, friends, and colleagues who may notice someone with a substance use disorder but don't know what to do. I'm proud to be part of one such education organization called LEAD, Law Enforcement Against Drugs. It is an emerging law enforcement school-based drug prevention program. It is the most emerging one in the United States right now. And it is the only law enforcement focused charitable organization offering evidence-based proven effective curricula from K to 12. And that's very important, that as we teach our young kids in the schools, that the programs we are teaching them is proven effective. Enforcement is certainly an important element in combating drug abuse. Making sure you are getting the people who sell the drugs off the streets to end this vicious cycle. But enforcement's not the only answer. We know in law enforcement we cannot arrest our way out of this problem. Addiction is recognized as a disease. Therefore, addicts need treatments. The problem with treatments is that some individuals with substance disorders don't have access or knowledge of the treatment centers. That's where law enforcement can come into play. We can help guide these individuals to these proper treatment centers. Research indicates that drug users are more likely to seek treatment shortly after experiencing an overdose. So speaking with someone about treatment after the overdose is positively correlated with seeking treatment. Sadly, it is not as easy as providing counseling and helping an addict get to a treatment center. There are many who already have that access and a strong support system, but resist it. That's because there is a behavioral aspect to substance abuse. And here is another area I believe that the police can help, as we carry some leverage, and because we interact more than any with the addicted people on the streets almost daily. Again, if we want to make progress in ending the opioid epidemic, we must ensure a combination of prevention, enforcement, and treatment. Law enforcement, health providers, elected officials, criminal justice, we must all work together to ensure the drugs are off the streets and the people who need the proper treatment get it. We did not get into this crisis overnight, and we will not solve it in a day. It will require all elements of society to work hard and to remain committed to fighting the scourge of drugs in our communities today. It's going to be difficult, but ladies and gentlemen, our children are dying. And the time for silos, egos, and finger pointing need to be in the past. We will only succeed if we work together, and I'm confident together we will prevail. Thank you.
I'm also short. Good morning. I'm Cheri Walter. I'm from the heartland, apparently. I'm from Ohio, and I'm thrilled to be here. I'm particularly impressed that in an event like this, I'm not sure why I was invited, but the fact that I'm in recovery, I think, is important. I'm in long-term recovery. I've been in recovery for 36 years. I'm also the child of a mother who died just a couple of years ago at the age of 86, an active opiate addict. She'd been an addict throughout her life, throughout most of my life, and had to have some treatment after having been in recovery for many years, ended up an opiate addict in an issue my family had to deal with. You know, I've been in this field for over 30 years, and people will tell you that an addiction is an addiction. and we have to address the underlying addictions in this disease. But the reality is, this disease is different than most. People become addicted to opiates much quicker than almost any other drug we've ever seen. We also know that because of fentanyl, which was a game changer, this drug is deadlier than anything we've ever seen before. And so we have people dying at a rate we've not seen with other addictions. You know, 2 to 3 years ago, most people would have told you, including myself, we would probably see the apex of the bell curve around 16 or 17. Nobody saw this fentanyl issue coming along, and it's changed the game. And I don't want to spend a lot of time up here talking about the bad news. I don't want to spend a lot of time talking about the disease, because frankly, my talking for 7 minutes in and of itself will be a miracle. But the reality is, I think the chief did a really nice job of laying out the problem. There is a problem out there. But the problem we're not talking about is the emotional impact this disease is having on our communities, and the emotional impact that this disease is having on our first responders, and the emotional impact that this disease is having on people who are addicted, who may or may not believe that they can recover. And that's where you as journalists, in my opinion, can make a huge difference. There's not a day that goes by in Ohio where I can't pick up a newspaper or listen to the news. In recovery can become good, productive citizens. How people on the front line are suffering because of what they're doing on a day-to-day basis. There are a lot of things we can do to address this epidemic. One of the big things in Ohio folks are doing is we have what are called quick hit response teams. We are seeing people Narcan, and by the way, Narcan has now become a verb in Ohio. You are Narcan. And, but we are seeing where folks are receiving Narcan time after time after time, and they're ending up in the emergency room time after time after time. They come out of their overdose, they're agitated, they stay for a little bit and they're gone. They don't stay long enough in the emergency rooms to hear about treatment. So what we now have is, we have quick hit response teams that include law enforcement, include EMT, includes a provider, a treatment provider, and it includes a peer that is now in recovery. They go out and visit the person who was saved the day before, the next day, when they're through, hopefully, they're coming through their overdose, and they start to talk to them about getting into treatment. These are the kind of things we have to do. We have to look at harm reduction. You know, there's pros and cons about needle sharing, about safe shoot sites, about letting people carry Narcan, about fentanyl test strips. Should we use them? Shouldn't we use them? You know, it really doesn't matter. What we know is if we don't keep people alive from the overdose and the addiction, they'll never get in recovery. We have to keep them alive first to even give them opportunity to be in recovery. We've got to do some of these things. One of the things in Ohio that we've seen, this disease has been rampant. And as I said, I've been in this field for over 30 years. When this disease first hit, when Governor Kasich first came on and he made this a priority, we saw a shift in stigma. We saw people who had never been willing to talk about addiction starting to talk about addiction, because people were being hit in suburbs and in wealthier communities. We were seeing young kids die, athletes who maybe got addicted. I mean, it was a different population, but we were seeing a different conversation, and stigma was reduced. Today, I'm here to tell you that that stigma is going the wrong way, and here's why. We have police officers, firemen, EMT, emergency room staff, who are saving the same person time after time after time. I had a county commissioner come up to me and say, Cheri, I have constituents that are coming up to me and saying, why do we continue to save these people? You're going to save them, they're going to come right back in our communities and steal and rob. What do we do about that? We have law enforcement that are getting repercussions because they save the same people time after time after time, and they just don't know what to do. We have to talk about the fact that this is a disease. If I had diabetes, it wouldn't matter how many times I end up in the emergency room because I ate too much sugar. The same has got to be true of addicts. So you, as journalists, can make a huge difference here. You need to tell the stories about what's working. You need to talk to people who are in recovery. I mean, I think that is, if there's one group of people that can tell you what works, it's the people that are in recovery, the people that have survived being Narcan, the people that have managed to put their lives back together, the mothers that have gotten their children back. They can tell you what works. We have to talk to them. We also have to help our first responders who are facing a secondary trauma like we've never seen before. In Ohio, the incidence of suicides among police officers, EMTs, and firemen is on the increase because of secondary trauma. We have to talk about that. We have to address it. I'm sure I'm at 5 to 7 minutes, aren't I? Because I can just go on and on and on. So if I could just say something to you, I mean, what I would say is, this is a disease. Addiction is treatable. And we have to start celebrating people in recovery. We have to talk about what's working. We have to tell stories. The only thing that's going to change this epidemic, like any other epidemic we've had, is when people's hearts are touched. It's too easy to stand back and say, that's not me. But I don't think there are many of us. In fact, I do a lot of speaking. I used to go around, I carried a $100 bill in my pocket, and I would say, anybody that can stand up and tell me one sector of society that's not impacted by addiction, I'll give you this $100 bill. I probably did that for 2 years. No one could ever tell me. Everybody's impacted. I think the chief was absolutely right. The silos have to go away. We have to come together. We have to address this from all aspects. But we have to stop talking about just how bad it is. And we need to start talking about what's working, what's good, and why we need to make a difference. People don't want to make a difference unless they know why. And that's what we have to let people know. Thank you.
Thank you very much for having me here. I come to you from the silo on the other side of the border before the war, right? but anyway, I think it's I'm gonna preach here, the gospel of binational cooperation and seeing this problem beyond just the heartland. The title of the panel it's an American tragedy, but I would go beyond and say that it's a binational tragedy, because as the same way the public health issue here in the US, it's really troublesome. Back in Mexico, the issue is completely the opposite, in the sense of violence has gone up terribly. 29,000 deaths in the past year, 2017. Probably the most violent year in recent Mexican history. And let's face it, violence in Mexico cannot only be attributed to US demand for drugs. It's attributed to weak institutions, impunity, terrible police forces at the local level, weak prosecutors, and obviously the issue of demand is part of the whole problem. Just to give you an idea, in the state of Guerrero, which is one of the opium-producing states in Mexico, this past year 7 municipalities had appeared on the most violent list of cities around Mexico. Just in Acapulco, which is the largest city in Guerrero, and where it could be where the growing of opium is not happening strictly in the city, but it's certainly one of the places where traffickers go to sell or exchange and try to control some routes. The homicide rate there is of 119 deaths per 100,000. It's terrible, it's unimaginable, and it's a real problem. Why does a book like the one by Simon Quiñones was so effective in telling this story? I think it's because Sam was a correspondent in Mexico City before writing this book, and he could see the issue from both sides, from the heartland, but also seeing the creativity of drug traffickers in Mexico to see a business opportunity. And back in 2008, 2009, seeing that obviously the prescription demand was there, and obviously offering a cheaper alternative in the form of heroin. You may know now that the heroin market in the US has completely changed. It used to be that Mexican heroin, black tar and brown heroin, was only present in east of the Mississippi, but now we know, and this is, you can go to DEA reports and obviously law enforcement local reports here, that now Mexican heroin is present everywhere in the US, crossing the Mississippi, and we see a refinement of heroin present in many communities. Colombian heroin is less and less there, and certainly this presents a challenge in how to create cooperation. I understand this as a public health issue, but certainly the supply issue would help to understand challenges that are coming or are here with us, like fentanyl and analogs and what comes later. If there's not a national angle to how you approach this subject, it's going to fail completely. In 2010, I became aware of this trafficking problem from independent organizations coming from the state of Nayarit, when I was interviewing chiefs of police in Columbus, Ohio, in Nashville, Tennessee, and they would always tell you, just like in Sam's book, that all the guys came from one particular municipality in the state of Nayarit, Jalisco. Jalisco was a cane-producing area that saw an opportunity due to the profitability of the heroin market and in sending small quantities, and this was in between 2008 2009. Now the problem has changed completely because the big drug cartel organizations have seen this issue as a profit, obviously as a profit area, and now they have also incorporated heroin among one of the multiple products that they offer out in the market. How do we go by now? Well, the thing is that I'm not that very optimistic, because it's been at least 10 years since the first signs of the heroin availability was here. We saw it since then with these independent networks from Nayarit. And so far, in the supply side of things, in the cultivation areas have doubled, seizures at the border have tripled, and we haven't seen a clear strategy between both governments to address the issue. The US continues to be focused on cultivation and trying to force Mexico into a better eradication of poppy fields in Guerrero, in Sinaloa, and other opium-producing areas, but we still lack a comprehensive, holistic approach to this. All experts on binational cooperation will tell you that the most important issue now would be to establish state control from Mexico in those areas that are poppy-producing regions. We don't have that, and with that, eradication would be completely futile. Also, the issue of police and law enforcement, criminal justice reform in Mexico is huge. It's something ethereal, probably for many of you, but wouldn't it be fantastic to have, if you're a local police chief, and try to contact your local police chief in Nayarit and say, hey, I got some guys that come probably from that area, you know anything? Well, they could give you some advice and try to break down the networks easier. Counter-narcotics cooperation in Mexico and the US has changed completely. It used to be a terrible relationship back in the early 2000s, but now after the signature of an initiative called the Marriott Initiative in 2007, things have changed completely, At the federal level, there are some good alliances that can be formed, but I think if I can leave you with something, I think it would be very important to continue a binational dialogue, always bring people from the other side of the border, and please don't forget about the issue of law enforcement and prosecutorial criminal justice reform in Mexico. Many advocates in Mexico are pushing hard on this, and I think in the end, that's the only way that we can be successful at those countries, having both strong institutions on both sides of the border. Thank you very much.
Thanks to all of you, each providing some really valuable information for us. But I'm going to go to Cheri first because she invited us to go there, and that's to the issue of what works. And I'm interested because you mentioned this collaboration of law enforcement, advocates, and public health, and even peers. That appears to be a unique setup. So I'm interested if you could talk a little bit about what it took to form that collaboration, because as we know, people do get stuck in these silos and are hesitant and even averse to reaching out across the line. So tell us about how that collaboration came together.
You know, it really started in a little town called Coleraine, Ohio, which is in southwestern Ohio, where this group of folks came together because they just weren't getting folks into treatment. They developed treatment access, which oftentimes, and still is at times in our state, a problem. They had access to treatment, but they just couldn't get people to go into it. So they decided to bring folks together to figure out if they talked to people, talked to families, and went to them versus doing it. When people are in an emergency room or they're in front of the police officer wondering if they're going to be arrested, it's a tough time to talk to them about possibly accessing treatment. So they wanted to do it on the person's home turf where they might feel a little more comfortable, where there could be family around, where they could see if they could get folks to come together. I think Ohio in general has done a pretty good job of bringing all the different parties together. The governor put something together called the Governor's Opiate Action Team, where he brought all the different disciplines from health to human services to law enforcement to education together to talk about how we can address this problem. But I think it was the folks at the local level that had to see the problem on a day-to-day basis that were able to do it. So these folks started talking about it. We have an opiate conference every year. They presented on it a couple of times. So then it moved up into Toledo, Ohio. They did it and they saw that it worked. So what really happened is, frankly, because of the new Cures funds that came down, our Department of Mental Health and Addiction Services put out some grants and said, let's see if this works. Our Attorney General put out some grants from his I think it was his victim awareness funds to try and do some of this. And so now we've got communities across Ohio that are doing this. They're putting together some best practices for how to do this. The one thing I would say, you touched on a little bit, a lot of folks don't think about bringing peers to the table because peers are not necessarily licensed or trained, but they've gone through it and they can speak to people differently. And what we know in Ohio, it is now, just as of this January, peer services has become a Medicaid billable service if you're a certified peer in the state of Ohio. Because what we know is, frankly, whether it's mental illness, whether it's folks coming out of the correctional system, you can call them a peer, you can call them a mentor. For years and years and years, I came up through the 12-step program. You had what were called sponsors. Those were the people that helped keep you kind of in touch with things, and as you were having problems, you could talk to them about what worked and what didn't. So we're finding that hooking people up once you get them into treatment with a peer will help their longevity of staying into treatment and staying into recovery. The one thing we faced, and again I can go on so I won't, but the one thing that we faced in Ohio was some of the treatment community was threatened with peers because they thought it was taking their role. We really had to work through that because there are turf kind of things. But now the treatment community is as receptive and supportive of peers as any other part of our state. And now our biggest problem is finding enough people to go through the training to become peer supporters. So I would really encourage you, and there's a lot of good kind of writing that can be done around what peers are able to do to help move this problem forward on the right direction.
Sure, jump in.
The only note I want to add, and that's excellent, I think you said so much of what I tried to say, but you said it much better. But, you know, if the analogy to me is HIV, we have a very long history of things like patient navigators, peer recovery coaches, or people who can really link you to care. So in the parlance of another epidemic, we talk about systems of linking people to care. And HIV, of course, you must be retained in care. And then you can measure it every step of the way. Did it work, and did we suppress the viral load? So you're talking about a linkage to care model with patient navigators, peer recovery coaches. Rhode Island really championed this. Ohio's doing some wonderful things. But we're also seeing, you know, police stations, the Gloucester model in Massachusetts. That's a linkage to care model. We're watching safe stations in New Hampshire and also in Rhode Island now saying fire stations can be that conduit, that place to link people to care. EMS, link people to care. Through your emergency department, we're learning a lot more from a Yale study and some others about starting buprenorphine or, you know, an agonist therapy, medication-assisted treatment or MAT, starting that in the emergency department, and really we're calling it induction. So bup induction in these settings can successfully get people linked into longer-term care. We're talking about primary care settings perhaps being these places where we can really start that process. So I love what you said, and I think just more broadly to think about all those opportunities and channels for linking people in a meaningful way, and I think that's a big part of our future, and of course coming out of correctional facilities as well.
Sure. Yeah, sure.
That's exactly what I was going to say, yeah. Our state is doing something also that I think is pretty remarkable. We're putting, and since this is a criminal justice setting, we're putting peers in local jails, and we're starting to induct folks on medication-assisted treatment in local jails. We have as many drug courts in Ohio as probably any other state. But anytime you have somebody where there's an opportunity to get to them when they're not high, and you can talk to them about the consequences of their use and the prospects if they get in recovery, is the time to do it. We really, really have to practice no wrong door. It doesn't matter where we get you, if we can get you and get you convinced that treatment works and that you can recover, we can make a difference.
Let me break up this block here.
Throw it over here.
And one of the important constituencies here obviously is law enforcement. And as you mentioned, Chief, you're often the first line in encountering people with this problem, with traffickers every day on the street. Nobody argues that this is a public health problem, but because you're often the first to confront it, are you having to drag public health to the table, or how much cooperation are you getting?
You know, I think when we look across the country, more and more states like Ohio, Massachusetts, New Hampshire are doing fantastic things with getting everybody to the table together. We're still far off from where we need to be. I don't necessarily think it's an issue of dragging anyone to the table, as much as is what I alluded to earlier. It's breaking these silos. Everybody wants to be the one who's doing the right program, the program that works. We have to really put those egos in check and make sure that we are working collaboratively. And I will tell you, for the journalists in the room here, we need you. We need you because no matter what program we look at, whether we're looking at the IACP's One Mind campaign, our new trust initiative, whether we're looking at CIT training or the programs that Ohio has, we need that message out there. Because I will tell you, half the people sitting in this room probably are not aware of the programs Ohio have. Matter of fact, if you go to California, half the law enforcement agencies and health agencies may not know about it. So what we need to do is really get, and I think you spoke about it earlier, what we do, we need to get out there to the public, the good things that we do. We need to make sure, and we need you, for the journalists who are in the room, we need the media to really help us in this venture, and we need buy-in. I don't really believe there's a wall up so much as for a lack of wanting to help. I think it's more territorial, and that's what we have to get through.
Well, there's obviously a confusion of roles, maybe. I don't know if that term suffices, but in communities across the country, especially law enforcement, you hear differing views on whether they're comfortable even with Narcan, which is everywhere now. Should that just be part of the police package these days, and what's being done to either encourage or just lay out where the line should be in this?
Well, I think today more than ever the line is blurred. I believe law enforcement, we're dealing with a lot of the other issues, and we have to wear many hats while we're out there. So I think as we have our new officers coming in, the training is very important. But I do believe it becomes a part of community trust. And when we look at the root of many of the issues dealing today with law enforcement and programming with their community networks, it's about building that trust up and building relationships. So I don't believe law enforcement officers are shying away from their responsibilities, but I think we do need society to recognize that we wear many hats, some that we were not hired to wear. I believe in my profession we're willing to wear those hats, and we need the support, though, for us to be able to do it right. We need the support from our community members, and it's only going to work if we have if we really have the trust of the community members, whether that's the health field, whether that's our community leaders, whether it's the peers. We need to build a trust, and I think there's programs out there. There's great programs. Operation Blue Shield out of Texas. It's a fantastic program that's bringing law enforcement into the communities. Like I said, the IACP's Trust Initiative, we just had our first meeting last week. There's a lot of different programs out there. We need to continue to work together, and I think as we build that trust, the support is going to be there for us. I do not think that law enforcement shy away from it, although I think it gets confusing for a lot of our new officers who are faced with things they never thought they would be faced with. You know, a lot of the other issues in society that we are held responsible for because we are right on the scene.
I want to go to that issue of trust because, Jose, you brought that up in your discussion about the binational issue between the U.S. and Mexico. What has to happen for that relationship? I mean, so much attention has been placed on, or the focus on the wall, and that's going to block the entire flow of illicit drugs, not only heroin and other drugs into the United States, but beyond that discussion, what has to happen for that relationship to improve?
Thank you. Just a quick note, I think, to the previous conversation, if I may.
Of course.
I think that I'll try to bring some optimism to you guys here, because even with the low resources or silos not communicating between each other, and all the different challenges that you may face here in dealing with the crisis, as seen from Mexico, all the local efforts happening in states like Ohio or Vermont or others are seen as pioneering efforts. Let's say, for example, a place like Tijuana, which is facing a rise in drug consumption, it's a city of 2 million people. It has just one public hospital, and it only has 30 spaces for those people who are interested in treatments on opiates. So there's a lot of things that you're doing here that could be exported at some point to other places around the world that could be of help. Dealing with the issue of trust, I think the first thing that has to be recognized, and I think it's important, is the issue of data. I think it's really frustrating that even with the close partnership that there is between the U.S. Law enforcement institutions at the federal level and Mexican institutions, it's incredibly frustrating that both sides of the border have not agreed on things as basic as cultivation estimates of poppy fields in Mexico. The DEA has some estimates that, at least publicly, doesn't show the exact methods through which they get the estimates. The Mexican side gets really angry about those estimates because they feel that they're not transparent. And obviously, the Mexican side also boasts about eradication numbers. That we've had the first year of the Trump administration a private fight on those numbers. Since January to now, they have not agreed on how to put out, some agreement on what's really happening on the cultivation side. If you extrapolate that to many other areas, I think that shows you that in order to build trust, you have to have a common vision of the problem, a clear diagnostic. But if federal officials cannot agree on basic data, I think that's why I'm a little pessimistic.
Did that data disagreement go back to previous administration?
Certainly, and it's not only that's constrained to Mexico specifically. Many other countries around the world have many issues with the way the U.S. collects its data, but considering that the U.S.-Mexico relationship is considered one of the most fruitful in terms of cooperation, it's frustrating that both, despite this confidence, they cannot produce some basic data that is agreeable on both sides.
How has, you mentioned the history of Mexican heroin moving in the United States and where it is pervasive now, but how has fentanyl changed that dynamic and the distribution across the country?
Yes, I'm not an expert on this certainly, but and it was something that was not seen back in 2008, 2009, as you were saying, something that no one else knew it was coming, but it certainly presents a challenge, and it's also it's completely difficult even to estimate. So there was a recent report by the Office of Senator Rob Porter that tried to present some numbers on how the U.S. postal system is being exploited to send some the fentanyl here to the U.S. and it's a problem that we don't know the dimensions. We don't know how much is arriving in Mexico. We don't know how much is being trafficked through the mail. It's so many parcels floating around that very basic thing is still missing, and I think it's a clear, hole that we need to try to overcome.
Sure.
Just a quick note on that. There are federal agencies that are trying to wrap their hands around, FedEx facility versus, you have a huge mail facility here at JFK, things coming through the dark web. It's very, very difficult. And the folks at DEA will be very honest and say, this is a uncharted territory, really, really difficult. But there are efforts to try to work with Customs and Border Protection and testing some of these unknown packages to know, is that where we'll find the next car fentanyl, but hopefully find it sooner? Where did it come from? Where is it going? So there's all kinds of efforts across the, agencies, and they don't always talk about them because sometimes traffickers will pick a new place to mail at them.
Right.
So, but yeah, it's really difficult.
I want to stay with you, Rita, just for a minute. I want to ask, just going back and looking back. I know this is about looking forward, but I think we can learn by looking back as well. Do you agree with then Attorney General Holder that this sneaked up upon us? Even though there's been discussion about how this epidemic has been different from crack because the demographics of people who are involved has shined a harsher light. But from your perspective, were we late and why?
Well, I'm going to put in a plug for my agency. We were one of the earliest ones to start talking about, actually we called it drug poisoning. We had an epidemiologist who was on a motor vehicle team and just kind of going through the mortality data and saying, this looks like we got a lot of deaths over in this category. What is this category? Oh, that's poisoning. And quickly we realized these are drug poisoning. And then we started to call it prescription drug overdose. And we actually had pushback from industry and folks who said, you don't know that. So we did investigations in a few different states. We have rapid field investigations and verified that the deaths, for example, in West Virginia, were due to prescription drug overdose. And as you know, the demographic of folks who were dying at that time were largely kind of middle-aged, a lot of white men. And people were particularly up in arms about those folks dying either, just to be honest with you. So I think that as the epidemic has changed, we do see different demographic groups that are more at risk. But in general, it's been going on for a very, very long time. I do think we were one of the early ones to say, hey, we have a problem, but there was no federal money. There was really no commitment, and we can't do anything unless Congress gives us money. So yes, we're late, kind of, yeah.
Can I make one comment on it? You know, I think what people did see coming but kind of got ignored a little bit, once the pill issue had been identified, Ohio truly was the home of pill mills. I mean, we had pill mills all along Ohio. We had one small community that had less than 100,000 people, and basically they were saying that if you looked at the number of pills prescribed, each man, woman, and child would have had over 400 pills per year. I mean, just crazy. But what happened was, our Attorney General and our Governor did a stellar job of coming in and closing pill mills. And they did it without putting anything in place to treat all those people that just lost all their pills. That's where the heroin epidemic came into place. If you take a drug away from a good addict, they will find another drug. And so we can get heroin off the streets, but if we don't find a way to treat people, we'll find another drug. I mean, for example, fentanyl, we now have examples of deaths in Ohio. Our cocaine overdose deaths almost doubled last year. And what they found is over 60% of those cocaine deaths included fentanyl in them. We had methamphetamine laced with fentanyl. We had 2 young men die in Northwest Ohio from fentanyl-laced marijuana, which was a first. So the thing is, if we don't treat the addiction, we'll find a new drug.
But I think it's important for journalists to know that clamping down on pill mills and regulating and better prescribing has not driven up the heroin problem. These things were happening at the same time. There's messiness, there's good science on it. We did a health affairs article that actually showed with rigorous science that heroin was going up everywhere. You had states with policies in place, states that didn't. So I don't want to give the erroneous impression that states should not try to improve prescribing. They should. We're still 3 or 4 times where we were in 1999. We're off the chart compared to European countries. It's still a significant issue, but and at the same time, that's also true that you want people to get the care they need. So.
Yeah, I'm not disagreeing at all with closing pill mills, but you can't just get rid of one thing. You have to put something in place to take care of it.
All right.
Were there groups, just to go back a bit, were there groups though, either in any of your experience, where you sounded the alarm and you got crickets back?
Our state began to take this most seriously when Governor Kasich was running for governor. He met with a group of mothers called Solace out of the Portsmouth area, which is really where the home of all these pill mills was. And they stand for surviving our loss together every day. But the bottom line is he heard them. And so when he took office, he absolutely came in, he and our Attorney General started to close pill mills. Where I think there were crickets was, I think the thought was, well, if we close the pill mills, we'll begin to dry up the problem. When people were saying, no, if you don't provide access for treatment, because if it hadn't been heroin, frankly, it'd have been something else. You have to treat folks who are addicted. You can't just take long-term prescriptions for pain away from people without giving them other alternatives to deal with their pain or to deal with their addiction. So in that sense, I think we got caught a little bit unaware and unprepared, and we've had to play a little catch up in Ohio, and now I think we're doing that. But I think in the haste to close pill mills, which absolutely was a good thing, and we've done a lot with prescribing practices, but we needed to catch up a little bit then to help all of those folks who lost access to those drugs.
And the question does come up a lot, did we miss the boat? You know, there's this expose on DEA, and they regulate how much can actually be sold. You know, they have an ARCOS data set of just raw, you know, sales in kilograms, and why was there so much allowed to be sold in West Virginia, for example? So I think there's been a lot of, like you were saying, finger pointing. But truly, I think as the death toll just climbed and climbed and climbed, and it was touching more and more people, that I think, and journalists, I bow down to all of you. I think you really tipped the tide and helped people understand this isn't going away, it's getting worse. It's a true epidemic. So I think some of that was at play as well, just people understanding that it's a true epidemic. The numbers just got completely out of control.
Chief.
And I think when we look at it, you spoke about crickets. I'm not really sure there were crickets out there. But I do think when we look at any issue facing our society today, one of our greatest challenges, and it's more of a question, is how do we overcome the slow burn? Whether it's terrorism, the HIV issues that we've had over historically, now it's fentanyl, and I can pick sexual violence. We tend to address the problems at a local level until it's almost epidemic, and then we start to gather the troops and gather the wagons together. So I guess the question is, as a nation, how do we start to gather those wagons together earlier when we start to see an issue starting to appear? But what happens is that, and pick a state, pick an organization, we are all working. I believe each organization was out there working to do what they could do to combat the issues that they were facing. But until it became almost epidemic, we weren't getting together with it. So, and I don't think the crickets were there, but by the time we got together to really move forward, it was already too late. And now we're trying to play catch up, and I think we're doing a great job with it. I have to say it. I think throughout the country we're doing a great job.
Just probably some tip for the journalists out there. I think a black hole out there, again, I'm preaching about the thing I'm talking about, but making the connection to overseas producers and everything. I think other than DEA, who has presence everywhere and has extraordinary professionals out there, I think there, for example, the case of Sam Quiñones, in 2010 he was with the Los Angeles Times interviewing people in West Virginia and Ohio, but it took like 4 years for him to publish his book. In the meantime, if there were journalists interviewing the same chiefs and could speak Spanish and read the Spanish press and could go back to Mexico and check the drug producing regions, they could come up with the story at the same time as him. I think that donors like the foundation here or others should really try to help journalists to go back to China in the case of fentanyl, or Mexico, and try to figure out some of the missing questions that are out there, and sometimes journalists are the best way to go, for a start.
I mean, what's blocking them from doing that now? But I understand the danger that exists, especially in Mexico, for journalists there to question what's happening in the drug trade.
I think one, you know better than me, budgets definitely. Very few reporters these days have budgets to go out and do field trips of, a month or less. But obviously budgets, obviously understanding of both sides. I think if you ask me for a recommendation that I could give out, I would try to have a journalist housed in one of the public universities in each state who could see specifically on trafficking, who could be stationed there connecting local people in Ohio and what's happening overseas, to try to make connections and try to work together in producing reports on where the product is coming from.
Very good point. I don't want to go over time. I'm not sure how much time we have left, but let me ask this. There's been some discussion about alternative strategies, some that are, at least in American thinking, pretty radical, like those that I mentioned earlier that Post had written about in British Columbia, managed injection sites, which have been around for a long time, just not here. Is the U.S. ready for that, Chief? I know you're not the
expert on that.
Not the expert, but in British Columbia, it's interesting. In Vancouver, I found in 2010 I was there for the Olympics, and one of the first places I stopped was this managed care place called Insight. It's right in town, just a few blocks away from the main headquarters of the Olympic Games, and lines of people waiting with their bags of dope to get inside and inject in a safe environment. On the other side of the street were police cars dropping people off to the injection site, which I found just fascinating. But is that something that you think we should consider? And how would police react to that?
Well, I believe, I work with peers around the world, and I see what does work, and I look at a lot of the innovative programming that's going on right now, and I commend them. I think what we have to look at is how do we change a culture of the U.S., and I think it's about culture change, and I think it has to be done in a way that people can absorb it, and I do believe we can do it, but we have to buy into the philosophy of thinking outside the box. We cannot continue to do things the way we've done them in the past, and that's a wide stroke there in a lot of different areas that we approach. We need to start thinking outside the box. We need innovative techniques, and we do need to look on the world stage, because the world is flat now. We need to look at that world stage, because everything we do, every other country is going through. We're not alone. And I think you talked about Mexico, you're absolutely correct, but it's not just Mexico. Across the globe, we are all facing the same issues, and we do have to look at best practices and how they have gotten to where they are with these programs working and what the results are. There's a lot of data out there. It's a matter of getting it and bringing it in, and then looking at the psychology of changing the culture. So do I think we're ready for it? I think we're getting ready for it. We are having a lot of issues, and I think people are getting tired of daily reading in the newspaper for law enforcement responding daily to our community members dying. I believe, and I'll speak for law enforcement, we're ready. It's getting us there and being able to present it in a way that we can absorb it and then get it out to our community members is the trick. But I will tell you, we want to help our community members. We're frustrated as they sit there. And we're not frustrated, and I know a lot of people, and I want to just clarify, I hear all the time that law enforcement officers can't stand going back out there and saving the same person each and every day. No further from the truth. No further. We don't want them to be there in the first place in that situation. And if we can bring them back 5 times, we're going to bring them back 5 times. You know, what we do, we put that badge on each and every day to protect our community in all aspects of protection. So I feel we want to do it. We're ready to do it. The trick is, how do we get there?
Can I say one thing as a sociologist? In every organization, leaders are much more progressive than the rank and file. This has certainly been my experience with law enforcement. And I think that some leaders in law enforcement are either ready or at least agnostic about where's the evidence. So Philadelphia made the determination that they think it makes sense there. Tom Farley used to be the health commissioner here. He's over in Philly now. But they looked in other places. Doesn't mean it would work everywhere. But the rank and file that I run across in law enforcement, I personally have not found them to be very ready. But I think there's a wonderful opportunity with leadership in any organization to, again, be courageous, be curious, and say we have to be open to new ideas. And the same goes for public health. I mean, in every organization, I think we really need to work on ourselves. But thank you for saying that. I think that's important for folks to hear.
Sure. Cheri.
I would agree. I think law enforcement, because they deal with it on a day-to-day basis, are probably more open than most. But do I think we're ready? No. And I'm a person in recovery, and I see this all the time. And I think the stigma, as I said earlier, is bad. It's getting worse. But the other problem right now, and I don't know if this is politically correct, but I'm going to go out there, there's a meanness in politics right now. And Ohio is a very conservative state. We actually have people that are talking about, well, the second time somebody's Narcan, maybe we should make that a crime. Really? We're going to criminalize addiction? Now, I don't think that's going anywhere, because I think, calmer heads will prevail. But I think when people don't know what to do, sometimes at a political level, what they try to do is just clamp down on everything, thinking that'll make it go away. When, if anything, it'll just put it in the shadows, and people won't come forward. They won't get help. And so we really, again, it goes back to this stigma. We have to fight the stigma of addiction, because it's just getting worse because of this. And I think it's because police officers, when I said they're facing secondary trauma, it's not because they don't care. But if you save the same guy 6-7 times and the next time you go he's dead, that's trauma. You've developed a relationship with this person, whether you know it or not. That is hard on folks. And I think our politicians are hearing how hard this is on folks. And when they don't know what to do, they don't go to the more innovative. They tend to go back to, wow, how can we make this stop? And that just doesn't always work. So I mean, as much as I would like to think we're ready to go there, I'm just not sure we are, because people think if you do that, I mean, we have people that worry if you give people Narcan and let them take it with them after they've OD'd, that you're just incentivizing them to OD again. I mean, those are the kind of attitudes that somehow we have to change. I mean, we wouldn't think twice about giving a diabetic insulin to take with them in case something happened.
The Trump administration has, in its budget, has indicated that it's proposing $13 billion. That's before you get to the cuts in Medicaid, which I'm not sure how much that'll bring that number down. However, but at the Justice Department, there was a recent announcement about marijuana policy and how the department was rolling back the Obama administration policy on enforcement, especially in states where marijuana is legal. How much of that policy reversal is impacting how the country, especially local government, is confronting the opioid crisis? Is there a giant mixed signal here? I mean, on one hand, you have the Attorney General saying marijuana is bad and we're going to enforce marijuana. It's still an illegal drug. Yet, we have, you're almost there to manage injection sites. How does that reconcile?
I'll jump in quickly. Medicaid expansion has been the single most important thing for helping individuals with an addiction in Ohio get treatment. Because addiction has never been considered a state or federal disability, and we know that people with serious addictions lose jobs. They also lose contact with their families, so they didn't get health insurance through Medicaid because they had children. If Medicaid expansion goes away in Ohio, there will literally have to be billions of dollars dumped into our system just to get all those people who got into treatment back into treatment. Medicaid expansion and our governor, as a Republican's willingness to go there, was seriously the best thing that could have happened to helping fight this addiction.
And also in Nevada, the governor, Republican governor, came out saying this would really be harmful to our efforts. Did you have? Yes. I'm a federal employee, so I'm going to plead the fifth on everything.
There's really no answer to that.
This is a safe haven.
The truth is exactly what you said. When you have mixed messages being sent, it causes confusion. Does it help the situation or hurt it? I think it confuses the situation. As you look at states starting to legalize marijuana, while the government is saying, no, it's not legal, we're not allowing it. I think the only way we're going to get through is to come to a consensus, and that's only done through really collaboration and working closely with our federal partners to make sure we end up on the same page, because if not, it sends that dueling message out there, and it continues to add confusion.
The confusing signals are not only restricted to domestically, but also internationally. It's very weird for Mexico to be under this paradigm of fighting, doing interdiction and seeing all the experiments in the States, and now changing the policy at the federal level in terms of marijuana. But specifically, I think many people in Mexico are worried about the change of attitude within the Justice Department, about whether we're going to go back to just focus on the kingpin strategy that has created, good things in some ways in terms of captures, but unintended consequences on the breakdown of the cartels in Mexico into multiple smaller bands, and which has created lots of violence. And also the issue is particularly on popular eradication, just focusing on that without the holistic strategy. It's also a bad signal that the Justice Department is sending in general.
On that point, are you seeing in law enforcement in Mexico a move to put marijuana back on a higher priority than opioid because of the directives coming from Washington?
Well, that's a good question. The current government, Mr. Peña Nieto, I think, proposed to make medical marijuana illegal in Mexico in general, but it has taken lots of steps for them to come up with the legislation itself. So the government itself, it's a little bit conservative in terms of how to deal with marijuana, but I think the public sentiment in Mexico is getting to a point of why are we fighting this issue when the demand is on the other side. I would argue that the problem in Mexico is much greater than demand. It's weak institutions, law enforcement that is not up to the standards. But I certainly I think there are weak, strange signals coming from Washington.
Well, I've been given the hook on the discussion, which I really appreciate. Everybody here has participated, provided some great information. But we'd now like to open it up to questions from you all. Anything that you have, please fire away.
We have a mic, some mics there. You want to choose one?
I'm Rick Rosenfeld. This is a question for CDC. Epidemics are fed by new initiatives and by continuing users. What I don't have a good sense of in currently in the opioid epidemic is what's the rate of new initiatives, people who are beginning to use and then become addicted to opioids, and how much, as opposed to how much the epidemic is continuing on the basis of, traditional users continuing to use. If new initiatives are dropping off, that would be...
Users. And some of the research that we reference says that about 75% of the heroin users started with a prescription. We have every reason to believe that number's changing as illicit opioids are much more available and the problem is sort of endemic. We're seeing some new illicit opioid users who start with an illicit. So I think that's one part of that kind of question. But for the brand new people, that is actually a different question about exposure. And I think that goes back to my point. We want to prevent unnecessary exposures. There are drugs for conditions when it's an appropriate drug, of course. But what we want to rein in is, for no good reason, say a 30-day supply, or things that you would say are not really indicated, like for many chronic pain conditions. So I think we don't really know the answer to that, but we know that that is still a significant pathway. So we're trying to, of course, we talked a lot about naloxone and treatment and things like that. So we're seeing prescribing is leveling off a little bit. It went up a bit. So I think we're still struggling with that.
So none of you have mentioned the elephant in the room, which I think is the fact that the pharmacological industry has created this epidemic, and I'm wondering if you would talk about that.
I just want to add a comment to the previous question. For the first time within the survey he's made among his people in different treatment centers, heroin initiates were the top ones.
We do, even if we don't think it is the most representative study, it's a good study, and we do completely expect that number will change, that more people will come to illicit opioids as their first taste of an opioid, for example. So the question about pharma, I think Sam Quinones did a really good job tracking it and showing the kind of the etiology, if you will. So I'm not sure that I need to say any more about that.
Well, I think
we're also kind of the heartland for all the lawsuits going on around with pharmacies and distributors. I don't think anybody can debate that there was certainly an issue there, but I think one other thing we need to think about, and I know Sam talked about this a lot, was the other thing is, in hospitals, they created this sixth vital sign, I think they called it, which was pain. And so they would evaluate individuals on, well, how is your pain being managed? And so again, I'm not letting pharmaceutical companies off the hook in any way, shape, or form. We have this expectation in America that a pill takes care of a problem, you know? A pill takes care of a problem. And so that didn't help either. So I think that medically, not only were they at the forefront on many of these issues becoming issues, but on the other hand, I've also seen many of them trying to do certain things to make this go away. And again, I'm not letting anybody off the hook, but I don't think you can just look at one piece of the pie medically and assume that that in and of itself was the issue. I think we have to look at kind of where medicine is in America.
And cost. I think cost is significant as well. That it's much cheaper to prescribe an opioid than to, say, go to physical therapy for 10 sessions or cognitive behavioral therapy. So there's a big issue about what gets reimbursed and paid for, and I think that that's an ongoing issue.
I have a question for Cheri. You mentioned that you're in long-term recovery, and you also, your mother was a user up until she passed away. And you guys have talked a lot about reacting to the epidemic, but I'm curious what you think, how important it is to tackle adverse childhood experiences. And most of the issues we see is cyclical cycles of abuse. And I feel like a problem with this epidemic is people have reacted, and there's still kids and families that are using and not getting the help they need before they become addicts.
You know, that is a wonderful question. In fact, I was hoping I would get a chance to talk about this, so I'm really glad you asked that question. We need to think about the number of children today. The number one reason kids in the state of Ohio are taken out of home and put into foster care is opiate epidemics by their parents. The number of kids, just in Ohio, I mean, we're looking at this past year, we saw a 39% increase on a report that just came out of the CDC from July to July. The number of kids that are having parents overdose. We had a school in one of our small communities where two first grade classes in that community, this is a community of about 100,000 people, 6 parents OD'd and died. Now think of the impact on that first grade class and these children. What are we doing? We've got a generation of kids that are coming up that have seen this epidemic, have lost parents, have lost brothers, have lost grandparents. We have more grandparents in Ohio bringing kids in and raising them because because the grandparents' kids are addicted, and the 50% increase of getting addiction. No one ever taught me about that. That's not an excuse. I mean, I could have learned about that. We need to teach these children this, but more than anything, we need to talk to kids about the trauma they're experiencing and help them work through it. I mean, and there are some great programs out there that are teaching kids about trauma, how to deal with their feelings, how to work through it. I mean, there's prevention. We need prevention starting at first grade, but frankly, we need it going all the way through school. But we also need to be dealing with kids who are experiencing trauma and not just kicking them out of class or suspending, but dealing with the trauma they're facing. That's a really good question. And I would say that's one of the areas we're not doing enough.
We're doing one study in Martinsburg, West Virginia, that specifically looks at adverse childhood experiences and linking. We know a lot about this. You guys probably heard about the ACEs, the ACE study. You count up all these adverse experiences. As the numbers go up, you see all these health conditions, including things like chronic disease conditions. And of course, mental and behavioral health, sexual risk-taking, HIV. List goes on and on and on. Drug use, substance use disorder. So we know ACEs are really that pivotal thing that if we could all get our collective selves together and pick that moment in time, we should all be addressing the ACEs for all kinds of health outcomes. So we're looking at that in Martinsburg, West Virginia, with the chief of police as the champion, providers, working with schools. So I think it's a broader issue about, you know, we have this epidemic now, what's the next epidemic? What's the next thing? So I think it would be an incredible investment in our communities. There's great science. Look at the Folletti study, adverse childhood experiences. It's a long-term study that they've done through Kaiser Permanente. So great question. Yeah. That's long-term prevention, and I think it's great.
And one other thing, this is another place where peers can play a big role. They're finding that if they hook young kids, even first or second graders that experience an adverse incident in their life, if they hook them up with healthy kids that are doing well with their families, it will help that child as well. Again, peers don't always have to be this real formal kind of process, but hooking kids who have experienced this kind of stuff up with kids who, and healthy, what is healthy? I mean, that's a whole other thing. But kids who seem to be doing pretty well and seem to have a support system in their life, hooking those kids up will help that child who experienced some kind of adversity.
Let me go over here.
Hi, I'm Lindsay. I'm with the Seattle PI, and we have a couple controversial things going for us in Seattle. We have legal marijuana, and we're also implementing safe injection sites. There's political resistance to both fronts, but if we can show that these things are effective, namely, I believe there are studies that places where marijuana is legal, there are lower incidents of opiate deaths. If stats can show that these are effective, can we break down political resistance, or are these maybe too controversial? Cheri, you mentioned that maybe we're not ready for these kinds of approaches.
That's a whole other issue, frankly. I think finding new ways, I think like the chief said, we can't do things the way we always have. I think jumping to the example that marijuana means less opiate overdoses is maybe true, maybe not. There's some studies that have come out of Colorado. We're also seeing that, at least in Colorado, a state that has legalized recreational marijuana, a higher incidence of suicides from psychosis. So, I mean, they all have pros and cons. But I think to your point, finding new ways to do things and not being afraid to evaluate if they work or don't work, and then trying to, you almost have to sell. You have to sell. You have to reduce the stigma and get people past whatever it is they think is going to occur, or whether or not they think this is promoting bad behavior. Again, I'll go back to whatever we can do to keep people alive without endangering other people is what we need to be figuring out how to do.
I think we've hit the limit here on questions. I hope we got most of yours anyway. But I want to thank the panel for all their contributions and your attention here today, and look forward to the discussion going forward. I also wanted to plug the gentleman's question about the drug industry, and I would refer you to the Washington Post series on that, which was spectacular, and I think was incredibly instructive to everybody in the country. Thank you.
Please join me in thanking So we're not done yet. As I warned you, we're going to go right to another panel. Can I have the panelists from the other second panel join me up here? You're permitted to stand up for 5 minutes. That's it right down here.